Why the heck adrenal insufficiency? Well, the Endocrine Society says that adrenal insufficiency is not managed well in the United States, so they got this committee together and they fed them and, probably high-fat food, and they said, make up some new guidelines about adrenal insufficiency, and they did. So we're going to whiz through these. Don't worry, you'll get to the beach. We're going to take a look at the evaluation and management of adrenal insufficiency. And they said, virtually everybody who treats patients and anybody who treats them with steroids needs to know how to manage adrenal insufficiency. So how many of you use steroids in your practice? How many treat Mary Jo with steroids? Oh, you're good guys. Most of you, we like you because endocrinologists look at folks who use steroids and like rheumatologists and say, oh, those people just create problems. All right. So here's a lady, she's 32 years old. She had hypothyroidism. She had that already, and she comes to my office once a year to say hi and get her prescription renewed and see if she has any problems. So she said, my skin's getting darker, particularly my gums. And lately I've been feeling dizzy. I stand up and I haven't done my strength training exercises, and I'm feeling kind of dizzy. So she brings a picture from a year ago. Last week, she brings her 2 pictures on her phone. Isn't that great? Your patients, my patients send me stuff saying, I got this rash. Do you think it's from my medicine? And it's attached to the Epic on this little, phone picture. It's just amazing. So anyway, her blood pressure, I took her blood pressure in my office, is 102/70 sitting and 80/60 standing. Oh, that doesn't sound good. Her lab had a potassium of 5.5, which is a little above our upper limit of normal. Sodium 132, a little bit low, and a little bit acidotic here. Oh, so she has hyperkalemia, and she has hyponatremia. She's a little acidotic. She has orthostatic hypotension, nausea, dizziness. And here's her picture. So here's her picture last year, and here's her picture this year. She's right. She's turning brown. What the heck could that be? And here, these aren't her gums. She obviously didn't have a mustache. But this is characteristic of, oh gosh, we're talking about adrenal insufficiency, right? So, primary or secondary? What does she have? She have a problem with her pituitary or her adrenal? Okay. Well, let's keep going. She had, remember that the laboratory evaluation of this requires a CBC. Sometimes they have anemia. They have relative lymphocytosis. They can have eosinophilia. Chemistry, you want to know about the glucose. They can have hypoglycemia with adrenal insufficiency, hyponatremia, metabolic acidosis, rarely hypercalcemia. Hyperkalemia is seen primarily in adrenal insufficiency, primary adrenal insufficiency. So in our patient's case, somebody got an ACTH, which was 5,000. Normal was up to 150. Her random cortisol was 4.5. and normal 7 to 20. So she has an elevated ACTH and a slightly low cortisol. So where is the problem? You think how many people think the problem's in pituitary? You people have to start this conference from the beginning and sit through the whole thing again. How many people think it's in the adrenal? Yes, you people can go home after this lecture. Okay. So you've made the diagnosis. She has a high ACTH and a low cortisol. And when you see someone in your office and you think, oh gosh, they may have primary adrenal insufficiency, don't just get a random cortisol like everybody does. Get an ACTH and a random cortisol. ACTH is high, cortisol is low. You've made the diagnosis. You don't need any fancy test. Only works in primary adrenal insufficiency. Only works well. Okay. So here we go. This is what you got. Weakness, fatigue, anorexia, nausea, vomiting. Almost nobody has joint pain. Patient comes to my office and says, oh, I just ache all over. I'm sure it's my adrenal. No, it's your fibromyalgia. Go down the hall. Okay. Rheumatology is down the hall from us. Okay. So, adrenal insufficiency, weakness, fatigue, anorexia. weight loss. Patients come to my office, they're sent over, they say, Mary Jo gained 30 pounds in the last 6 months, and she's feeling dizzy and fatigued. She has adrenal insufficiency. Never on this earth. Even if you have congestive failure and adrenal insufficiency, you lose weight because you have a sodium leak directly out the kidneys. You don't have any aldosterone. Things don't go well. The other thing you have is hyperpigmentation. Why? Well, there's controversy about that, so I'll just answer that for you. The ACTH doesn't pop out of the pituitary as ACTH. It's made as a large promolecule that oozes out of the pituitary and is cleaved as it's leaving the pituitary. And part of that molecule has melanocyte stimulating hormone capacity. And so it stimulates the melanocytes and you turn brown. So if the ACTH is very high, you're very liable to get hyperpigmentation. Okay, this is case 2. She's a 38-year-old lady who came to the ED with nausea, dizziness on standing, weight loss, back pain for several weeks, blood pressure 130/70, but no orthostatic change. Her E group was normal, and someone got a random cortisol. If I could just stop people from ordering random cortisol, my life would be so much simpler. It was 0, leading to panic and a call in the middle of the night. And I said, well, is she talking to you? Yeah. She's awake and she's standing up. Oh, yeah, blood pressure's 130/70. I said, the cortisol may be 0, but she has steroid on board somewhere, right? Otherwise, you'd be dead. Okay, so just be calm. Patient comes to your office, they're feeling a little funny, you get a random cortisol, right away that was a mistake, but you get a random cortisol and it's 0.2. Forget it, she's got steroid on board. We had a guy who had we couldn't figure it out. He had a cortisol that was like 0.5, but he was perfectly fine, he was asymptomatic, there were no problems. And I said, somewhere you have steroids on board. So he said, no, I don't use a dexamethasone inhaler. No, I haven't taken prednisone for poison ivy. No one has injected me in the back or the hip or the leg with anything. Okay. He had pericarditis, and someone was injecting him to calm down the pericarditis with steroids. Took us about 3 or 4 weeks to figure that one out. Okay, so look at this lady. Dr. Clark keeps telling us to look at these people and describe what we see. Well, does that lady look like she stumbled into the wrong lecture? Why? I know I'm taxing your brain here, but look at her. She has a red, round face. Look at those supraclavicular fat pads, folks. This lady looks like she has temporal fat pads that are enlarged. This lady looks like she has Cushing's, right. So what's she doing in this lecture? Well, we took a history. That was unique for the ER. Are there any ER docs here? Oh, thank goodness, they've all left already. Anyway, that was unique. We went down and I said to the fellow, take a history. She looks Cushionoid. So why is she in here for adrenal insufficiency? Well, for the past year, she'd been getting prednisone 40 milligrams a day for connective tissue disease. She decided it wasn't doing her any good and stopped it. Oh, heck, that just makes you sick. So we explained to her that was a poor move and left the ER. Okay, case 3. Case 3 is anyone aged 25 to 70 comes to your office with complaints of nausea, dizziness on standing, weight loss, fatigue, who has just recovered from meningitis, stroke, traumatic brain injury, all sorts of illnesses that affect the brain in total. And those people can also get adrenal insufficiency. Now, it's not from their adrenal. The last 2 cases, the adrenal isn't having a problem. The pituitary and the hypothalamus are shut off. So the E group is generally normal in these people. The ACTH may be low normal. The cortisol is just a little bit below normal. Something isn't working right. Okay, so now we have a bit of boring biochemistry. Remember, the hypothalamus makes corticotrophin-releasing hormone that goes to the pituitary, anterior pituitary, causes you to make ACTH, which goes to the adrenal, causes you to make cortisol. And aldosterone, to an extent, most of the aldosterone is regulated by the renin-angiotensin system. Right? Right. Okay, so only a third of it's regulated by the pituitary. So the aldosterone and the cortisol, mostly the cortisol, feed back to the pituitary and the hypothalamus. All right. So what happens in primary adrenal insufficiency, like our first lady, adrenal's gone, so ACTH is high, corticotropin-releasing hormone is high, and they don't make aldosterone because the adrenal is defunct, so they get hypotension. All right. What happened to our second person? Pituitary was shut off by a large amount of steroid, large dose of steroid. Pituitary is shut off. Adrenal doesn't work very well, minimal adrenal hormone production. Sometimes you can't even measure it. And the corticotropin releasing factor is high, the ACTH is low, and the cortisol is low. So they're both low. It's a pituitary problem. That's patient number 2. Patient number 3, oh, traumatic brain injury. I see that all the time because we take care of folks from Fort Hood, which is one of the biggest Army bases in the world. A lot of sad traumatic brain injury, and those people lose the higher centers, and so they don't make corticotropin releasing hormone well, and so they make some, and the pituitary makes some ACTH, and the adrenal kind of gets the idea, but these people sort of limp along, and they're hard to diagnose and just initially in your office because they just don't feel well. And you say, oh heck, you're like the fibromyalgia lady that's telling me you have adrenal fatigue. No, these people actually have adrenal directional problems. It's like the lady who doesn't have regular menses and ovulation because her gonadotropin releasing hormone isn't coming out right. This audience kind of reflects with that, doesn't it? Okay, so let's go to what happens when you just measure a random cortisol. I hope I've talked you out of it by now, but here you are in the morning. You see the cortisol, like the ACTH, comes out in bursts. So if you measure it up here, you say, oh, Mrs. Schmedlife has Cushing syndrome. If you measure it down here, you're going to say, no, Mrs. Schmedlife has Addison's disease or adrenal insufficiency. So one random cortisol doesn't do it. If you have primary adrenal insufficiency and it's low and a tandem ACTH is high, you've got the diagnosis. Secondary and tertiary adrenal insufficiency, you can't do it with a random cortisol. So please don't waste everybody's money getting that. So what do? You stimulate with ACTH. So I'd ask you, what happens when I give you ACTH? Do you make cortisol? Does it matter? Yes, you do. I have to answer my own questions here. That's all right. Yes, you do. If I give you ACTH early in the morning, will you make cortisol? Yes, you will. If I give it to you after lunch, will you make cortisol? Yes, you will. If I give it to you when I've given you a big dose of steroid, yes, you will. But I won't be able to measure it because I gave you a big dose of prednisone and it cross-reacts. So, again, whenever I give you ACTH, you will make cortisol if your adrenal is working. So, you use the business part of ACTH, which is cortisone, and you give it, and you measure the cortisol at 30 and 60 minutes, and if it's 18 to 20, the patient does not have any problems. And I don't care if they have fatigue and nausea and weight. No, they don't have any problems. Okay, so what is a normal stimulation test? There you go. I give you ACTH, you make cortisol. How about primary adrenal insufficiency? I give you ACTH. Let me see if that doesn't look like it's doing well here. I give you ACTH and I get nothing. As a matter of fact, they whapped that off the bottom of the slide. And if you have secondary or tertiary adrenal insufficiency, I get something, but nothing like what I should have gotten. Okay? So you can differentiate those two with a cortisol stimulation test. Looks like this microphone says its battery is dead. Can you still hear me? Okay. Alrighty, so ACTH is the key to location. If it's high, it's primary. If it's low, it's secondary or tertiary. So if you're going to persist and get that 8 a.m. cortisol, get the ACTH. It tells me where it is. High, primary, low, secondary, or tertiary. So what causes primary adrenal insufficiency? Well, in the United States, autoimmune disease, far and away. Congenital adrenal hyperplasia is an inability to synthesize cortisol and aldosterone. If it's total, gives you primary adrenal insufficiency, but it's found at birth. And so if you're not a neonatologist, you can forget that one. Worldwide, tuberculosis is one of the most common causes of primary adrenal insufficiency. It goes into the medulla, destroys the medulla and the cortex. Secondary adrenal insufficiency. Oh, far and away, you cause it. Actually, the rheumatologist, the gastroenterologist cause it. People giving folks injections with steroids, steroids for poison ivy, steroids for bronchitis, cause adrenal insufficiency. So again, that's the most common kind in the United States. You can also have pituitary surgery, hypothalamic trauma, again, but not very common. So how are we going to treat this? Primary adrenal insufficiency requires both something to replace cortisol and something to replace aldosterone. So a glucocorticoid and a mineralocorticoid. Secondary and tertiary adrenal insufficiency are usually diseases from which you recover, and they just require glucocorticoids. Well, in Texas, sometimes it's really hot. People get dehydrated. I give them a little bit of mineralocorticoid. But for the most part, secondary and tertiary require only glucocorticoid replacement, and the patient may recover. Primary adrenal insufficiency requires both glucocorticoid and mineralocorticoid replacement. Patients don't recover. Very, very seldom do you recover from primary adrenal insufficiency. Your adrenal's gone, that's it. Now, the other thing you need to teach is people about emergencies. And I know that bracelets accept Fitbits, although I had a guy with a Fitbit that has his adrenal insufficiency tag on it. You've got to have a tag, a necklace. Somewhere we've got to know your phone isn't going to work. You have an automobile accident, they leave the phone on the seat, they bring you in the ambulance. Somewhere we need to know you have adrenal insufficiency because you only have steroids on board for 1 day. In an intensive care unit, we got to figure it out. It's a pain in the neck, it costs a lot of money, and you may die. So I convince my patients to wear some sort of a tag or a necklace telling folks they are steroid dependent and have adrenal insufficiency. How do you replace them? Glucocorticoids, I've just told you, hydrocortisone, 10 to 20 milligrams in the morning, 0 to 10 milligrams in the evening. Prednisone is 5 to 7.5 milligrams a day. Those are the two you ought to use. You don't want to use unusual things to replace adrenal insufficiency. Divided doses are given, and you're going to give the last dose in the afternoon because you can create insomnia out the wazoo by giving the last dose as the patient goes to bed. It'll keep you awake. They're really great. If you can't wake up, steroids are a really great way to do that. No, just kidding. Okay, so if you want, you can try a single dose in the morning to help with compliance if they always forget the afternoon dose. How much? Well, I gave you the doses, but really, probably we're treating people with too much, which is the other thing the Endocrine Society said we have to emphasize. Too much steroid in most of our patients. Hydrocortisone 20 and 10 is probably too much. And if you see signs of cushingoid features, you get the red face, you get round, patients begin to get a little upper abdominal obesity, try and reduce the dose, particularly the evening dose. Also make sure the patient has an injectable steroid they know how to use in case they throw up for a whole day. How long does your PO steroid last? 1 day. So if you throw it up all day, you're going to be steroid deficient. You don't want to end up in the ED. So please show them how to use Solu-Cortef. It's really easy. You can get it in a pre-filled syringe in most pharmacies. And tell them when to double the dose. You don't double the dose when your guppy dies or when you break your toe. You double the dose when you have pneumonia, bronchitis. You tell the anesthesiologist when you're going to surgery so they can give you a bolus. It's for really significant events, you double the dose. Mineralocorticoid replacement is only indicated, we said, in primary adrenal insufficiency. And you use Florinef. There's only one thing, fludrocortisone. And you have to tailor it to the patient. And you start out with 0.05 milligrams a day. Some of my older patients that have fluid retention only need to take it twice a week. Some people need to take more. Depends on whether you're salt sensitive or not. So just you have to tailor that to the patient. Start off low, and if their feet begin to swell up, reduce the dose. If they're hypotensive or the potassium is high, you raise the dose. Okay. Now, how about you've put somebody on steroids and you need to get them off? Well, mainly you're putting them on steroids for something, right? I mean, you just didn't do it because you felt like it on Tuesday. You're putting them on because they have polymyalgia rheumatica, they have polymyositis, they have hip pain and you injected them. So you're giving them extra steroid because of an underlying condition. Injectables taper themselves, so you don't have to worry about that. But if you're giving them PO steroids in high dose, you can taper down to replacement doses. You just looked down on the previous slide, replacement dose, and then you've got to be careful of adrenal insufficiency. Down to replacement dose, you're tapering based on the disease. You're tapering based on the disease. You don't want to get flares in the disease. You're going to taper down to replacement dose, and then you say, gosh, patient is better from their underlying disease. I want you, I get these people in my office in droves, to get them off steroids. Okay, I'll do it. And how you do it, remember that if you treated them for more than replacement for more than 3 weeks, they are going to need to have a little taper. So if you're going to give people something for poison ivy or bronchitis, oh, I beg of you, use one of those packs that just tapers itself, because then you don't have to worry about it. I mean, they really do work. They're actually evidence-based. So but if you're going to put them on high dose for something for a long time, like polymyalgia rheumatica, we're probably going to have to taper them very gradually off once they get to replacement dose. So how do you do it? Everybody has their own way to do this. Every endocrinologist I've ever talked to has their own way to do it. This is my partner's way. She likes this one better. And I said, okay. You find the smallest dose you can, like 1 or 2.5 milligram tablets, and you have people back off. Remember, the half-life of prednisone, for example, is 12 hours. So every 3 days, you have 5 half-lives. You back them off by 1 tablet, either in the morning or the afternoon. You alternate back and forth, morning or afternoon, and if they get sick, you go back to the previous dose. And what I do is I actually take I print out a sheet so that they know where they're going, and I put dates on it so they know on what date they're going to be taking what dose, and it's pretty effective in getting them off. You probably ought to keep the AM cortisol at, roughly speaking, if you're using hydrocortisone, 10 to 15. You don't want it excessive, but you don't want them to be running in the 4 to 5 to 6 range where they're going to be having symptoms. And at the end, you do a cortisol stimulation test to see if their adrenal is up to snuff. I have to tell you, oftentimes it is in the mid-range. They don't quite get to 18 to 20, but if they're in the 10 to 12 range, 12 to 15, they can make it. Okay, so this is our last case. This is a 56-year-old homeless male presented to the ED with hypotension, nausea, vomiting, weight loss over the last 2 months, and a lack of appetite. They suspected adrenal insufficiency. What do you do next? Well, please, we're thinking what kind of adrenal insufficiency? He's homeless. He's been sick. We're thinking primary adrenal insufficiency here. This guy hasn't been in to see his local doctor to get 40 milligrams of prednisone. He could have had a traumatic brain injury, but he didn't have any problems. He didn't look sick. He hadn't had any injuries. The only thing he had was he's getting the dwindles while he's living under a bridge. Okay, you draw the ACTH and the cortisol, please, both of them. You're not going to wait around. He's sick. You're going to give him IV dexamethasone in emergencies. Why is that? Because then I can do a cortisol stimulation test and find out if you're right with your discussion. Because when I give you ACTH, will you always produce cortisol if you can? Yes. And so if I give you dexamethasone, it doesn't interfere with my assay. I come along the next day, I do a cortisol stimulation test. In the meantime, you've covered him with steroids so he won't die, and you don't have to call me in the middle of the night. You hydrate him with D5 normal saline, and you give him hydrocortisone after the cortisol stimulation test, and you have just passed the endocrinologist's test of what to do for adrenal insufficiency. So, in summary, Adrenal insufficiency, you can diagnose with a cortisol stimulation test. ACTH tells you, is it primary when it's high, is it secondary or tertiary when it's low. And therapy, you replace the cortisol in primary with the aldosterone. Secondary, you replace cortisol only. And the dosage is based on body surface area. I've given you that calculation in your handout. For emergencies, you don't know if they're adrenal insufficiency, cover them with dexamethasone, cortisol stimulation test, then IV hydrocortisone, 100 milligrams Q8 with D5 and normal saline. Oh.